Hello, I'm Michael Failings, Professor of Neurosurgery at the University of Toronto. I'm very pleased to have contributed to the revised Yeoman's textbook of neurosurgery. And the topic that I'll be speaking to you about today will be on the pathophysiology and treatment of spinal cord injury. At the outset, I'd like to acknowledge the co-authors on this chapter, Lorraine Hatcham, a neurosurgery resident at the University of Toronto, Greg Harlock, who is currently on faculty at the Health Sciences Center in Winnipeg, University of Manitoba, and Lonnie Schneider, a PhD at the University of Utah. I'll be talking about the epidemiology of spinal cord injury briefly, and in particular emphasizing the evolution of the epidemiology with the shifting demographics that we're seeing. I'll talk in some detail about the pathomechanisms of spinal cord injury, including the phases of spinal cord injury, the concept of primary as well as the secondary injury mechanisms. And then I'll be focusing on some of the barriers to repair and regeneration. I'll talk briefly about the management concepts of spinal cord injury, including the principles of non-operative management. I'll be talking about the concept of time as spine, the importance of early surgical decompression, and where are we currently with existing neuroprotective treatments and what is in the pipeline in terms of emerging therapies. So the learning objectives are fourfold: to understand the underlying mechanisms of secondary injury and spinal cord injury, to apply an understanding of the pathophysiology of spinal cord injury to optimize management, to understand the current clinical practice guidelines for the management of spinal cord injury, and to be aware of emerging neuroprotective, neuroregenerative, and neuromodulatory strategies to optimize outcomes after acute spinal cord injury. So this is a map of the world and which illustrates the estimated incidence of spinal cord injury across the world. And you'll see that actually a relatively small proportion of this map is colored, and in fact we lack granular data for many regions of the world in low-income countries and developing economies, where the incidence of traumatic spinal cord injury is likely very high. But we do have very good data for North America, for Europe, and for Australia. And in general terms, the incidence ranges between 20 to 40 per million. The main causes of injury in the developed world relate to motor vehicle accidents, falls, and sports-related injuries. Work-related injuries, which used to be a very common cause of spinal cord injury, fortunately are less common in the developed world, but in emerging economies, we still see that this is an important area. And then in some areas of the world, for example, highlighted here in South Africa, we see that acts of violence, including penetrating spinal cord injury, is a very important cause of traumatic spinal cord injury. It's also clear that the epidemiology of acute spinal cord injury is changing. The overall incidence, despite proactive prevention measures, remains stable. And the reason is that we have an aging population, so the average age of spinal cord injury is rising. And this relates to more fall mechanisms and more cervical injuries. So I'll be illustrating the concepts and the pathomechanisms of acute traumatic spinal cord injury in the next several slides. But I thought I might illustrate this initially by relating some clinical slides, then with some of the critical pathomechanisms. So here's a patient with a bilateral facet dislocation at C4-5. This is on an MRI scan that shows a very severe contusive injury at C4-5. And the high signal in the T2-weighted MRI is indicative of what's referred to as a secondary injury. And this is in the ischemic penumbra. Now, this is a post-mortem sagittal section through the cervical spine, fortunately not from this patient, but from a patient with very similar mechanisms of injury. And you can see here the primary mechanical forces that resulted in this acute trauma. You also get a sense of some of the secondary injury mechanisms that might be involved. So there's clearly ongoing compression and instability. And if you look within the cord, it's contused, there's hemorrhage within the cord. And this suggests that vascular mechanisms may play a role. This is a microangiogram from a rodent experimental data in which the rodent cord has been contused and compressed with a modified aneurysm clip. We've then microinjected the blood vessels to achieve this microangiogram. These are the anterior sulcal vessels, and you can see here that the central arbor has been traumatically disrupted, and there's hemorrhage. And in this area, necrotic cell death predominates. And this is in the central gray matter and the medial white matter. In the surrounding lateral white matter, we see a zone of ischemia, and this is the ischemic penumbra. And if we look at nerve fibers in this region that have been stained for a neurofilament protein called neurofilament 200, we see that there's a progressive degradation of these axons. And this largely reflects the influx of calcium, sodium, and the activation of proteolytic cascades. This then culminates over the ensuing weeks to months in the pathology of a chronic spinal cord injury. And this is a human postmortem photomicrograph. So the necrotic debris has been resorbed through inflammatory mechanisms, and one is left with a cavity. This refers to myelomalacia. This is surrounded by the astroglial scar, and we see a retrograde and an anterograde degeneration of nerve fibers. So again, we have the concept of the primary injury. These are the primary mechanical forces that cause the injury, and then this sets in motion what's called the secondary injury, a complex cascade of molecular and cellular events. And then this is divided into the acute, subacute, and chronic stages. In the acute stages of injury really refer to the first 24 to 48 hours. The subacute phase of the injury is in the first 2 weeks, and then this gradually evolves into the early chronic and then the established chronic phases of injury. And the established chronic phases of injury are defined by the glial scar, which is in place at 6 months after injury. Now, the mechanisms of cell death in secondary injury differ from those from the primary mechanical trauma. So necrosis is the primary mechanism of cell injury with the primary injury, but apoptosis or programmed cell death is the main mechanism of cell death in secondary injury. And this is a cartoon of a cell, and we see that there are receptors on the cell surface, which are called death receptors. And these are activated by various ligands, including the Fas ligand. And then there are various adapter proteins that translate this information and activate a proteolytic cascades called caspases. And then this ultimately cleaves the DNA and results in cell death. Ischemia is a key contributory mechanism, as I showed you pictorially before. And the ischemia leads to dysfunction of the energy-dependent sodium-potassium pump. This results in cytotoxic edema or subsequent cellular swelling and activation of proteolytic cascades. One of the key secondary mechanisms is related to ionic dysregulation and excitotoxicity. This refers to the pathologic release of glutamate, which then secondarily leads to intracellular influx of sodium, calcium, and then this activates deleterious enzymatic pathways. One of the critical secondary injury mechanisms that is then triggered relates to mitochondrial dysfunction, and this dysregulates ionic homeostasis, and there's a loss of the transmembrane potentials with the release of free radicals. And you see what occurs is you have a positive feedback loops, which are then activated. So these free radicals cause a number of forms of cell injury. One of the key types of cell injury is related to reactive oxygen species, and then this damages the lipid membranes on the cell surface. Subsequently, neuroinflammation is also critical. Initially, there's disruption of the blood-spinal cord barrier, there's influx of inflammatory cells, and then subsequently, there are also the intrinsic inflammatory mechanisms, principally microglia. And these cells, in turn, induce the production of a number of inflammatory mediators, including TNF-alpha, interferons, and interleukins. What's important to recognize is that there's a dual role for the inflammatory cascade. This is the yin and the yang, if you will. So there are positive, beneficial effects of inflammation in terms of wound and tissue healing, but there are also negative effects in terms of amplification of the secondary injury cascades. Now, the central nervous system, unfortunately, poses numerous barriers to regeneration, and critical to these are myelin and extracellular matrix inhibitors. And many of the myelin inhibitors act through a common receptor. This is called the NGR receptor. And so, for example, some of the critical inhibitory molecules which are expressed in the myelin include NOGO, MAG, and oligodendrocyte myelin glycoprotein, and there are a host of others. In addition, in the extracellular matrix, in the astroglial scar, there are chondroitin sulfate proteoglycans that are expressed, and these also are inhibitory to regeneration. The activation of the NGR receptor then in turn triggers various secondary pathways, and this includes the Rho-ROCK pathway, which then downstream modifies the actin cytoskeleton, and this leads to growth cone collapse on regenerating axons and thus inhibits regeneration. And there have been various strategies which have been studied to try to block a NOGO through antibodies and as well through pharmacological approaches to try to interfere with the Rho-ROCK pathway. So glial scarring, as I've indicated, reflects largely the reactive astrocytes, and these form a physical barrier around the lesion. Now again, there is a yin and a yang. The glial scar is helpful in terms of limiting the primary damage, but it also unfortunately serves as a barrier to regeneration. Although, intriguingly, there are some aspects of astrocytic physiology which may also be beneficial to regeneration. And current areas of investigation are actually looking at this potential dual role of astrocytes, trying to differentiate those that inhibit regeneration from those that positively influence repair, regeneration, and plasticity. So let's get now down to some practical reality in terms of the management of acute spinal cord injury. And patients should be rapidly mobilized to a specialized medical facility with cervical spine precautions on board, and the use of cardiac, hemodynamic, and respiratory monitoring devices are critical, and patients should be looked after in a monitored setting, such as an intensive care unit or step-down unit. The neurological assessment is critical. We recognize that there are certain spinal cord injury syndromes, which are shown here on this slide. Critical to the accurate neurological assessment is the use of the so-called ASIA or INSCI standards. And this is shown here on this slide. And so there are standardized myotomes in the upper and lower extremities that are assessed, as well as the quantification of pinprick and light touch sensation in the sensory dermatomes. And then one should decide on the neurological level, which has a sensory and a motor component to this. And then in many cases, there's what's called a zone of partial preservation, where there's a partial preservation of a neurological function. And then one uses the Asia Impairment Scale, which ranges from A, this is complete motor and sensory loss. B has sensory sparing, and it's very important to assess a potential sparing in the sacral region. And then C and D are incomplete injuries, with D injuries having grade 3 out of 5 motor power in the key myotomes. And then an E level on the Asia Impairment Scale refers to an individual that had a spinal cord injury but is essentially fully recovered. So critical to the management of acute spinal cord injury is a recognition of the critical aspect of hemodynamics. So autoregulation of spinal cord blood flow is disrupted with critical zones of ischemia. And as a result, we have this phenomenon of neurogenic shock. And this needs to be distinguished from spinal shock. So neurogenic shock refers to hypotension and bradycardia. And this relates to the loss of descending sympathetic tracts, which innervate the cardiac accelerators in the upper thoracic cord. In contrast, spinal shock refers to the immediate loss of reflexes, bladder function, and muscle tone below the level of the injury. And this is distinguished from neurogenic shock. So the treatment of neurogenic shock initially involves volume expansion, but one generally limits this to 1 liter of a crystalloid or colloid, and one then quickly goes to inotropes to act on the cardiac accelerators which have been denervated. So it's critical to avoid and correct hypotension and to maintain mean arterial blood pressure at 85 millimeters of mercury or higher. It's also critically important to understand the respiratory effects of a traumatic spinal cord injury. Of course, as everyone recognizes, the diaphragm is innervated from C3 to C5, but injuries below C5 will also cause profound impact on respiratory function because of the paralysis of the intercostals. And there's a significant reduction in the FVC and the maximum inspiratory force. Months after a spinal cord injury, the intercostals become spastic and the chest wall becomes rigid. The FVC and the maximum inspiratory force partially recover, but the cough or maximum expiratory force is still markedly impaired. So the clinical signs of the key respiratory issues are defined by rapid shallow breathing, atelectasis, and importantly, about 1/3 of patients with cervical spinal cord injury will require intubation, and this is preferably done via an awake fiber optic technique, although if those skills are unavailable, an orotracheal intubation with inline traction is an acceptable alternative. Now, surgery has a critical role in the early management of acute spinal cord injury. The largest trial that has been done demonstrating the beneficial impact of surgical intervention for acute spinal cord injury is the Staskis study, which was published nearly a decade ago. And this showed that in patients with an acute cervical spinal cord injury, the odds of achieving a 2 or more grade change in the Asia Impairment Scale was almost 3-fold higher in patients who had early surgical intervention within 24 hours. And this and other lines of evidence have then prompted the development of guidelines which suggest that the optimum management for any patient with an acute spinal cord injury be within 24 hours. And these data have been further strengthened by a recent work from our group published in Lancet Neurology in a set of over 1,500 patients. In here, we provide strong quantitative evidence favoring early surgical intervention within 24 hours. And it's very likely that within the next several years, we'll see a revisitation of these guidelines with a further strengthening of these recommendations. And of course, corticosteroids remain hotly debated, but the AO Spine Guidelines group has also recommended that this can remain justified as an option for selected patients within 8 hours of injury at the physician's discretion. And in my own practice, patients with who are younger with cervical spinal cord injury are ideal candidates for this intervention. So what's in the pipeline? There are a number of neuroprotective strategies which are currently under investigation. These include the anti-inflammatory drug minocycline, riluzole that I'll discuss in a little bit more detail in a moment. This is a sodium glutamate antagonist, magnesium and polyethylene glycol, fibroblast growth factor analog, cooling, both systemic and local, as well as CSF fluid drainage. So this video will illustrate some of the concepts that are being examined with the sodium channel blocker riluzole. So this is currently under investigation in the phase 3 randomized controlled trial called the RISCUS trial. Here I'm modeling a subaxial cervical burst fracture, and this sets in motion the secondary injury cascades. And we see sodium rapidly entering the cells. There's an influx of water, there's cellular swelling, there's calcium entry through the sodium-calcium exchanger. And then there's a subsequent pathologic release of glutamate, which triggers excitotoxic cell damage. And these are the critical mechanisms related to the secondary injury processes. So in the RISCUS clinical trial, what's being studied in patients with cervical spinal cord injury is the combination of early surgical intervention, which we're here modeling in this a case of a cervical burst fracture with a corpectomy and anterior reconstruction, and then riluzole is administered within the first 12 hours after injury in an effort to try to attenuate these secondary injury mechanisms. There are also other emerging therapies, including neuroregenerative strategies, and a number of these are targeting myelin-associated inhibitors of regeneration, and in addition, there are a number of cellular therapies which are under investigation. And most prominently, I'll just talk about Schwann cells from the patient themselves, as well as neural stem cells, which increasingly are being investigated from an induced pluripotent stem cell source. Complementing this, there are also neuromodulatory and neurorehabilitation strategies which are under intensive investigation. And these include functional electrical stimulation, paired corticospinal motor neuronal stimulation, and epidural stimulation. And a very interesting area that will be emerging in the practice of neurosurgery is the confluence of functional neurosurgery and complex spine surgery. So in summary, spinal cord injury results from a primary mechanical trauma, which is amplified by secondary injury mechanisms, including apoptosis, ischemia, excitotoxicity, and inflammation. Myelin and extracellular matrix inhibitors are important barriers to functional regeneration after spinal cord injury. Neurogenic shock requires proactive treatment. Early surgical decompression is critical to facilitate recovery. Future directions will explore promising neuroprotective therapies and emerging neuroregenerative treatments. And on that note, thank you very much, and I hope you find the chapter in the Yeoman's textbook of interest.